Hey guys, guess what? I am finally early with this PowerPoint. I figured you guys had the test the other day, gave you a day off, and I figured I would start in on the next lecture. So, anyways, we are going to start out with healthy lifestyle, healthy behaviors, and then I will record the next lecture in a different section. So, Healthy People 2020 is basically a framework that was put to try and get where the people of the world of America are healthier. They feel that an individual's health is correlated with the community health, and the community's health is related to an individual's health. So it kind of goes back and forth. Sorry, I'm just closing my door. So what they want, Healthy People 2020 wants a society where everybody's living long, healthy lives. There are 4 different goals that are listed as Healthy People 2020, and you can kind of read these, but basically they want people to live high quality, longer lives, and without diseases that are preventable, disabilities, injuries that are preventable, basically anything that's preventable. They want health equity, to eliminate disparities, poverty, those types of things, and better health for all different types of groups. They want to have social environments and physical environments that promote good health for all. An example of this is, at school they are now going to a different type of diet. I know Westby School does whole grain breads and pastas. They're not allowed salt shakers. I don't know how much ketchup they're allowed. So it's just different environments that promote this good, healthy lifestyle. And they want to promote a good quality of, or high quality of life, and behaviors across all life stages. So from young kids all the way up to older adults. Health promotion is just the behavior that is completed or motivated because the person desires to have a better well-being and a better health as a whole. It's not related to any disease, and it's basically a personal approach to wellness. It's a positive idea. Disease prevention or health protection. This is a behavior, but for health promotion, it's generalized. For this, it's a behavior that's motivated to avoid an illness, detect it early, or continue to function after the disease is diagnosed. So it's very specific to this illness, very specific to this injury. Somebody's trying to come in my room. It's midnight. You wouldn't think anybody'd be up in my house, but they are. All right, so prevention. Primary prevention is more of a focus on health promotion and protection against specific health problems. Its goal is to decrease the risk or decrease the exposure of a person or the entire community to a disease. So an example of this is immunizations. Say the measles immunizations. I know some people are not vaccinating their kids, so the measles virus is coming back. But primary prevention is giving your child the measles vaccine so that they don't get measles. Another one would be the varicella vaccine, which targets the chicken pox. So just remember that primary prevention is protection against specific health problems. Secondary prevention, their focus is on the detection of health problems. Kind of identifies a person in the early stages of their disease and really works at decreasing them becoming disabled because of the disease. So if someone detects rheumatoid arthritis, begins Enbrel or whatever treatment they might need, it will actually decrease the degenerative changes like the joint deformities and because it's an autoimmune disorder, all the infections that can actually lead to disability. So secondary prevention is early detection of health problems and completing steps to decrease the incidence of disabilities related to that health problem. Tertiary prevention, the focus is restoring a person's health after a disease or an illness has struck. You want this person to get back to the highest level of functioning possible. So if you have a patient that had a stroke or was in a car accident, they go to physical therapy, occupational therapy, speech therapy, so that they can learn how to walk again or learn how to complete their ADLs in a way that is new to them but allows them to be more independent. That is tertiary prevention. So tertiary prevention is restoring and rehab after a disease or illness or an injury has struck. You want that person to get back to their highest level of functioning, whether it's exactly what they were doing before the accident or if they have to, manipulate different ideas and thoughts of how to get back to the highest level of functioning. All right, so health behavior is the different things that people take to understand their illness, their health condition, keep that high level of health, what they're doing to prevent their illness and injury, and reach their highest potential or their highest level of functioning. Health behavior actions they're supposed to be done to prevent illness, disease, or even provide early detection of disease. But health behaviors are things like you exercise daily to prevent obesity, or you eat right to prevent diabetes, those types of things. So I want you guys to know the stages of health behavior change. So once somebody decides that they are going to make a change in their healthy behaviors, which you guys will do for the health promotion plan, there's different stages that a person goes through. I think there's 6, but I can't remember off the top of my head, but we'll go through. Each stage has its different, what the person is doing during these stages. They may recycle through the different stages over and over, or they might just go straight through. It just kind of depends on that person. They may relapse. I think I will use, I have smoking right here on this slide. So I'm just going to use smoking as our healthy behavior change. So a pre-contemplation stage, this person's not considering making any changes within the next 6 months. So if they maybe have tried to quit smoking in the past and ended up smoking again, they may feel that them quitting smoking is not going to happen. They won't talk about it, they won't read about it, they won't think about it. They don't have a problem. They don't see their smoking as an issue. So pre-contemplation stage, they're not planning on making any changes within the next 6 months. There's no problems. Contemplation stage, these people start to understand that there might be a problem with their smoking, or that they recognize smoking as a high-risk behavior. Maybe they had or knew someone who passed away from lung cancer, and so it kind of really hit home in there. Oh yeah, maybe I do need to quit. So they're starting to seriously consider stopping smoking, and they're going to start going around gathering information. Maybe they're going to learn, look up Chantix or Wellbutrin or other medicinal ways to help quit smoking. They might discuss their plans, and their plan is to actually start the process within the next 6 months. Um, Sometimes people stay in this stage and they never actually start playing out their change, but at least they're starting to contemplate and realize that, hey, yeah, smoking is bad. I need to quit. This is what I want to do. I want to do the patch. I want to do Chantix. I want to do Wellbutrin. I want to do the gum. So contemplation, this person is just starting to understand, and there's going to be, they're discussing plans to change within the next 6 months. Preparation stage, they're planning their behavior change within the next month. So there's an immediate plan to make a change. They may have started making small cognitive changes. They may have already spoke to their doctor about getting a prescription for Chantix, or maybe they've already filled their prescription. Maybe they have figured out another habit to pick up instead of smoking. So instead of every time they smoke a cigarette, when they want to smoke, they're going to eat a carrot stick or suck on a sucker. So they're kind of finalizing everything and getting ready. So this is just the preparation stage. So the preparation stage is within the next month. Action stage, this is where they're actually carrying out their behavior. They tapered down their smoking. They're eating suckers every time that they want to smoke a cigarette. They've started Chantix. They're eating carrots, whatever it is. But they're stopping their bad behaviors and starting their good behaviors. Maintenance stage, their new healthy behavior is now becoming part of their life. It is just becoming, just as smoking a cigarette after a meal was part of their life, now sucking on a sucker or chewing a piece of nicotine gum after a meal is now part of their life. This will continue until the temptation to smoke another cigarette is gone. Sometimes at this stage they've quit smoking for a while and they're doing their healthy behaviors, and something will happen. They'll become stressed out and they may relapse. Sometimes this stage can be as short as 6 months, and sometimes it can be as 5 years or even longer. Termination stage, this is where that person has complete confidence and they aren't going to smoke anymore. Even if they go out to a party and have a beer, they're not going to have their cigarette with their beer, and it actually appears like this person was never a smoker. Their new behavior is automatic and definitely part of their life. They're not trying to make it part of their life anymore. It's just automatic. So termination stage, there's no longer a chance for relapse, and this person won't pick up another cigarette. So what is our role in health promotion as a nurse? We need to model that healthy lifestyle. I will tell you, I'm probably the most unhealthy nurse there is out there. If you see me walking in the hall, I generally have my energy drink or my candy bar or some pizza or some kind of crazy food. But we need to model our healthy lifestyle. We need to encourage our patients to be involved in their assessment, their implementation, and their evaluation. If they want to make a change, we need to have them involved. If they're not involved, they're not going to make the change. We educate our patients. We need to assist our patients, their families, their communities, to choose these health-promoting options, whether it's a mother of 4 brings in one of her children for a well baby check. Well, maybe we can really encourage and educate that mom that all 4 of her babies, not just the one that came in for a well baby check, but all 4 of those babies need to be vaccinated against the chicken pox or whatever immunization. They're just trying to make sure that they're all up to date on their shots. That's kind of the gist of that part. So, in everything that we do, nursing process is a piece. So we had nursing process in teaching earlier, and now we have nursing process in health promotion. Um, so in any time we use nursing process, our first step is assessment. We are going to find a health history. We're going to do a physical assessment. Um, so it'll kind of tell us any problems that they might have. Always need to consider the person's age in the assessment. For example, a 90-year-old is not going to be as active as a 20-year-old. They're not going to be able to run the mile that the 20-year-old can run. We are going to maybe do a physical fitness assessment, how their strength, their endurance, their flexibility, and their cardiorespiratory type stuff. Like I said, remember a 90-year-old is not going to have the same results as a 20-year-old. We're going to look at their lifestyle. Maybe their current health choices are not so good and they are affecting other areas of their health. Spiritual health assessment. I did put one of those up, or there are a couple questions for a spiritual health assessment for the health promotion plan. But it doesn't have to mean God or any specific higher power. It's just kind of getting someone to develop their inner fullest potential and their purpose in life. One really important thing that sometimes we miss as nurses in health promotion is the support systems. We need to ask our patients if they can list their support people and their relationships, whether they're a friend or mother or father, and really help those people identify the support people that have been there for 5+ years. If they've been there longer than, just a short term, sorry, my dog's going to come in here and lay down. But if they're here for a longer term, they're going to be a better support person than if it's just a short-term person, if that makes sense. I'm going to kick her out pretty soon. Okay, she's out. A health risk assessment. This is kind of a thing that's done to determine a person's risk for injury, disease, illness. Kind of looks at all the aspects of a person's life, their lifestyle, where they live, their general health. So that kind of looks at all of that and provides recommendations to reduce their risk. Some of those things are not going to be changeable. Like for an example, multiple sclerosis is like a Midwest disease that's very highly populated in the Midwest and not so much in other areas. So that's not something that can be changed, but we live in Wisconsin. Everybody drinks beer in Wisconsin. We're known as the beer drinking state. So maybe that's something that can change. Maybe someone's drinking too many beers a day. Their health beliefs review. Kind of what a person feels like their own health is. How can they control their own situation? So for an example, if a health beliefs review is done on the Amish culture, they will tell you that their God determines what happens, even if a child is sick. I had a Amish. I love taking care of the Amish. I think they're a wonderful culture. I know some people might have different views or have heard different stories, but I think they are a wonderful, wonderful group of people. Even despite this story, this story is a hard, difficult story. But in our area, we had a family who gave birth to this little baby, and she had, I believe she had congestive heart failure. But she had a heart defect, and she was filling up with fluid. And they had been to the doctor, and we do have our doctor that takes care of the Amish down here. We got a few of them that do. And they had prescribed Lasix for the baby. Well, the Amish really felt that whatever was going to be, and if that baby was to live, they would do it without intervention. If that baby was going to die, then that was what God wanted for the baby. So the baby did end up dying. Parents never gave the Lasix, and the baby filled up with fluid and died. But because she was not old enough, they had to do CPR on her, and it was just a very sad situation. But we had to respect that their culture feels that their God is going to determine what happens. So, life stress review. I don't know if you guys have ever done those. You go through and you tally up what stress you've had. I think it's in the past year or something. I did these once and I about fell over. I really don't know if it's a good tool to use or not, but as you add up the numbers, it can tell you how high your stress level is. While you guys are in nursing school, I do not recommend taking one of these because you will see that your stress levels are sky high, as if you didn't know that already. So our next step in the nursing process is a diagnosis. And yes, we're going to use our nursing diagnosis. Generally, it's going to be impaired or imbalanced health patterns, impaired or imbalanced health problems. We can do the desire to enhance, just kind of so that it's saying that there is a health issue. Sometimes we can have readiness for enhanced, whatever, learning of whatever issue they're facing. So basically, the health promotion NANDA diagnosis helps make a clear plan for any interventions without indicating there's a problem. So they're saying that they are ready for enhanced learning related to weight loss, weight gain, those types of things. So our next step is planning. As the nurse, we are going to work with our patient to decide the goals, the interventions to reach the goals, the frequency or the duration of how long we're going to do it, and how we're going to evaluate. So in the planning stage, we're going to review and summarize all the data that we picked up in our assessment. We're going to look at our patient and reinforce their strengths. So if we have a patient who is obese, we can go back to our smoking. That might be. Maybe their strength is finding a distraction from when they want to smoke. So we could use that. So we're going to identify health goals and behavior change options. So we're going to identify that we want them to quit smoking. And then we're going to find our different options of what they can do. Chantix, Wellbutrin, the patch, suckers, carrots. We're going to identify any health outcomes that they may see. They're going to be breathing easier. They're going to get their smell back. They're not going to be coughing when they wake up. We're going to develop this plan that summarizes what behaviors are going to change. We're going to keep reiterating with our patient the benefits of this healthy change. Keep telling them, you're not going to wake up feeling like crap. You're not going to be coughing up a lung when you wake up. You're not going to smell when you go to places that don't have smoking near them. Those types of things. We're just going to really drill home of the benefits of what their lifestyle change is going to be. We're going to talk to our patient about people that will help, like facilitators, and barriers to change. Maybe their spouse is not a smoker, so their spouse is really going to help them quit smoking. But maybe their mother wants them to come over and have coffee and smoke cigarettes with her. So just really kind of determine what's good support and what might be barriers. We need to determine a time frame. So within 1 month, we're going to help them cut down to 5 cigarettes a day. Within 2 months, we're going to have them cut down to 3 cigarettes a day. And then just kind of formalize their commitment to making this. So if they see it in writing, that will generally help them make their plan and follow through with their goals, their interventions, and see their outcomes. Implement. This is the doing part. This is when the person takes full responsibility. We can support, we can counsel, we can facilitate, we can continue to teach, we can model, we can help them out, we can encourage all of those things. But the patient is the person that needs to follow through with this part. We cannot be there with them every time they feel like they're going to smoke. We can't be there to slap their hand or throw them a piece of nicotine gum. This is the part where they need to do it. And evaluate. We're always going to be evaluating our patient on their goals. Once they actually reach the part where we can start evaluating, they can, decide to stop or continue with their plan. Maybe they don't need to have the nicotine gum every time they feel like a cigarette. Maybe they just need to chew on a carrot now. We're going to try and figure out their priorities. If there needs to be any changes. So say they go out for Friday fish every Friday night at the bar. Well, maybe the bar is a huge trigger for them wanting to smoke. So maybe we need to change it up a little bit where they just order out fish and have somebody else go pick it up, so they don't have to go into that bar and put themselves in this situation. So the nurse and us as the nurse and the patient are going to be evaluating and trying to find what worked, what didn't. So if you remember nursing process, we always do the assess. If there's a problem, we need to do something about it, and we need to evaluate it. So kind of look at the whole nursing process. For everything we do in nursing. Assess, diagnose, plan, implement, and evaluate. So I hope that all makes sense. If you have any questions on that, please let me know. I feel like I kind of rambled about it, but tried to give you examples and ways to remember each step. Alright, so health promotion for babies. This is the birth to 1 year. These babies, their main task is they're just adjusting to life outside the belly. For physical development, babies, when they go in for their well baby checks, the provider or the nurse is going to use these growth charts to measure where their growth is compared to other babies, whether they're in the 50th percentile or the 5th percentile. So their psychosocial development is this trust versus mistrust. The baby depends on their parents or their caregivers to fulfill all of their needs. They cannot do any, obviously they can't do anything for themselves. When a baby cries because they're hungry and the caregiver brings them a bottle and feeds them, they gain their trust. So if they cry and they're hungry and their caregiver doesn't bring them a bottle for an hour, and so they cry and they cry and they cry, they're not going to trust their caregivers. So every time a need is met in this age, they build trust. Anytime a need is not met, they mistrust. Hope that makes sense. Cognitive development, they're just kind of learning as they go. By 12 months, they are, can do things, but they're not just reactive to what they're doing or to their environment. They're able to do things, whether they're walking or babbling or pulling themselves up, but they're able to do a few things and understand Moral development, they're starting to understand right and wrong. Mom and dad are telling, or caregivers are telling them no. If they're realizing that some behaviors get rewarded. If they do something nice and good, and that the parent is proud of, the caregiver is going to smile. They're going to pick the baby up and cuddle, and they're going to really learn voice tones. Whether they're going to learn that when they pull somebody's hair, they hear no, and when they blow raspberries on somebody's face, they're going to get snuggled and hugged. So they're understanding that if I do this, this is how they're going to react, and that's a good thing. But if I do that, they're going to react this way, and that's a bad thing. Health risks. Safety concerns are a huge risk in this group, whether it's SIDS or they are kind of mobile. They're crawling, they're walking, up to a year they might be walking. Some of these babies are actually going to have failure to thrive, where they're eating and they're just not gaining weight or growing, which is that baby up in the right-hand corner. Some of these babies might have colic. Child abuse is a huge health risk for this age. Shaken baby syndrome or abusive head trauma or inflicted traumatic brain injury. It's very, very true, and it happens more than we like to admit. We had a baby in our rural hospital that was dropped off by, I believe, the father or the mother. I can't remember, one or the other. He was 17 days old and was unresponsive. They dropped the baby off and ran. Did not leave a name, did not anything. Dad had been babysitting. I shouldn't say dad was babysitting because it's dad's responsibility to watch his child too. But dad had been watching the baby, could not get him to quit crying, so he grabbed him by the ankles and hit him on the side of the bed and hit something else. Well, that caused him to be unconscious, and I believe there was a broken bone or two from that. But then when they did while they were doing x-rays, new bruises showed up. And when they got the x-ray results, the 17-day-old baby actually had healing fractures. So don't, we all see babies as cute, but don't let it slip your mind if you're assessing a baby and there's something off. Assessments and things to do for this age, the birth to the 1 year, the infant. APGAR scoring we're going to do at birth. We went over that last week or so. We're going to continue doing the developmental screening test. They're going to start doing language. They're going to do gross motor. They're going to do fine motor. They're going to do personal social type developmental tests, see how they're reacting to people. And then we're going to continue doing nursing, physical nursing assessments, head to toe type things. All right, toddlers, 1 to 3 year olds. Physical development. Toddlers are chubby with short legs and a large head, a protruding belly. Their curvature is, their lumbar curvature is a little more pronounced. Weight, generally we say 30 pounds by 3 years old. And during this time frame, their gross and their fine motor abilities are improved. They can control their movements a little bit more, whether they're stacking blocks or walking or those types of things. Psychosocial development, they are in this autonomy versus shame and doubt. Toddlers are starting to become more independent, and when they can't be independent, they really feel like they're doubting themselves. I'm going to see if I have the picture in this one. No, I don't. But I have a picture in one of my slides. It says something, if you always do everything for me, I'm going to think I can't color. I'm going to think I can't cut. I'm going to think I can't, and it goes through and lists all these things that we sometimes just automatically do for our kids, and they just become more dependent on us, and they feel bad that they can't do it themselves. They may throw some temper tantrums when they can't get something done independently, and we may see separation anxiety if parents are dropping off at the daycare. They may become upset that their parents are leaving. Um, Toddlers, sometimes this is where we see a little bit of regression. I think it's more common in the preschool age. Yeah. Cognitive development, they're starting to develop a lot more in this 1 to 3 age. They're developing their intellectual, they're understanding concepts. Moral development, so right around the time that they are finishing up in the infant stage, they're understanding, if I do this, I get rewarded, and if I do this, I get in trouble. This just really gets drilled home in the 1 to 3 year range, especially the 2-year-old terrible twos. Spiritual development. This age group might repeat short prayers. Now I lay me down to sleep. I pray the Lord my soul to keep. If the caregiver is, citing one line at a time, they might be able to repeat these short prayers. But that's about all their spiritual development really kind of is. Health risks for these 1 to 3 year olds. Injuries are the biggest cause of death in toddlers. Now that they're toddlers, they are very mobile. They can run, they can walk, they can run, they can jump, they can ride a bike, they can do all sorts of different stuff, and they don't have the safety awareness that an older child will have. So they may, now that they can run and walk, they might see a ball run out in the road and they roll out in the road and they might run after their ball and get hit. Or they might start. They don't have the idea that if I stand too close to the edge of, I don't know, a porch, they don't have the idea that if I fall off, I'm going to get hurt. So they might fall off a porch and get hurt. They may have vision problems. A big risk is the dental caries, the cavities, and respiratory tract and ear infections are very common in this. So those are the major health risks in the toddler age. For their health assessment and promotion, we need to really educate our parents or our caregivers on their growth and development, their health status, what to watch for. Really, really educate on accident prevention. They're going to start wanting to toilet train. A lot of kiddos are toilet trained by 3 years, but some are not. And we really need to stress good dental hygiene because they are at high risk for the cavities. If you look at these pictures, they kind of show, kids 1 to 3 year olds are able to actually push a chair up to the stove. And sometimes if the knobs are, some of the stoves have the knobs right at where they can reach them. If it's a gas stove like the one in this picture, they might climb to see what's up there or get into the cookie jar and bump that knob and actually turn on the gas stove and burn themselves. They're more curious, so even if the pills aren't left out on a table where they can see them, they might go find them in the medicine cabinet. Because now, like I said, they can push the chairs up, they can reach things higher up. And educate parents to not leave any sharp objects down, especially like the scissors here. Anything that they can get into because they don't understand that it's going to hurt them. And the same with electrical wires. So I think that's pretty much it with the health promotion. Always, I have it on here pretty much every age group, but as nurses we should be doing a full head to toe physical exam. Preschoolers, 4 to 5 year olds. They're growing faster in their height than their weight. So these kids are going to be pudgy, chubby little toddlers. They're going to start looking taller and thinner. 4 to 5 year olds, I don't know, about 40 to 45 pounds. And the average height is about 41 inches. they are going to be in Erikson Stage's initiative versus guilt. They're going to start showing initiative to solve their own problems, but sometimes they're going to feel guilty if they don't get it right. Oh, there's that picture. When you cut it for me, when you write it for me, when you open it for me, set it up for me, draw it for me, or find it for me, all I learn is that you do it better for me. So this actually fits the preschoolers better. They're taking the initiative to cut it. They're taking the initiative to write it. It may not be perfectly written. They're taking the initiative to open it. They may rip the box, but they still get it open. But those types of things. And if they can't do it and caregivers continue to do it for me, they'll feel guilty and they'll feel like, hey, I can't do it. Cognitive development, they're learning. They get trial and error. They are huge observers. They like to imitate. They'll practice playing and make believe. They only really kind of deal with one idea at a time, and they're starting to learn how to read, and they're starting to learn how to do math problems. Moral development. These kids are learning that they should behave well in public. They don't. They act different in public than they do in their own home. They're learning that if they keep their behavior in check, or they do a certain behavior, they'll get more affection from their parents. So they're learning how to take turns. They're learning how to share, and they're really going to model behavior that they see. If they see fighting all the time, then they might be a little more rambunctious and, swearing or whatever. But if they see a calm, relaxed environment where people are caring about each other, then that's what they're going to do. Spiritual development, again, they're going to imitate the behaviors of who they see, their parents, their teachers. They may use their imagination and, talk about the devil or angels or see angels or see the devil. Health risks. Preschoolers' health risks are pretty similar to the toddlers, except for they are going to have a higher risk for communicable diseases, whether it's the flu or the chickenpox or lice or whatever, the cold, because they're going to daycare and they're going to school. And I'm sorry, but daycares and schools are just little germ factories. You can definitely tell a difference during the school year when kids are in school versus when they're at home for the summer, because they catch every little thing when they're in school or going to daycare. Preschoolers, they're going to start asking questions when we're doing the health assessment. If we listen to their heart, they're going to ask, oh, what does that sound like? Or is it okay? And those types of things. We really need to educate our caregivers on the accident prevention, the dental health, the nutrition, which we'll get into in the other slides, enough stimulation, because it does make a difference. I have two nieces that are the same age, and one of my nieces is, my sister-in-law is a teacher, so she's really worked with her, and and my other niece, they don't work with quite as much, and they are two totally different kids, and they're totally different levels, but they're the same age. And it's because one of my nieces has been stimulated so much. She knows her colors. Red too. She knew her colors. She knew her numbers. She knew her letters. Like they would go out to eat, and she would be picking letters off the wall. She'd be like, "That's a F. That's a M." And people would, because she's small for her age anyway, and they would literally ask my sister-in-law, "What are you doing to that kid? Do you drill her?" And no, because there's so much stimulation at home, she just picked it up. A big thing we need to teach our caregivers is that these kids are getting enough sleep. They're going from being able to take naps and doing whatever they want to do, sleep in. Maybe they get carried out to the car and go to daycare, or maybe they have a stay-at-home mom or a stay-at-home dad, so they can sleep in. They don't have to get up for school, and then they can take a nap anytime they want. But once they start preschool, yes, they do have a nap in preschool, but how many kids actually are able to take a nap? Um, so they're going, they're going to have, they go now where they have to get up early in the morning, they're going to school, they're busy all day. So by the time afternoon rolls around, they're really tired. Um, and if they don't go to bed at a decent time and get enough sleep, that just wears down on them. You guys know what sleep deprivation is like. Um, yeah, so that is preschoolers. I think we covered pretty much everything. School age. This is the six years old to 12 years old. Weight gain's rapid. They might start some pre-puberty changes. Um, they are going to be in this industry versus inferiority. Um, they want to be. They want to feel like they're worth something. So what can they do? What can they build that makes them feel a sense of worth? Uh, if they can't get these things accomplished, then they're going to feel inferior. So they have, for cognitive development, they're starting to think logically. They understand the relationship between cause and effect. If this happens, then this is going to happen, or this is going to cause this to happen. They have better understanding of concepts. And then moral development. By the end of the school age, they act how their parents or their brothers or their sisters would want them to act. Spiritual development. They're going to start asking questions about God. This is kind of about the same time that they start confirmation. They may pray and become frustrated when their prayers are not answered. They may not understand that, not every prayer gets answered the way they want them to, so they may become frustrated and question God. Health risks for the school age. It is the communicable illnesses, the cavities, and accidents. They're all pretty much the same things as preschoolers. But the new risk here in this age group is obesity. Um, Kids this age, the younger age is really kind of running around playing, whether they're playing house or kicking a ball or whatever. But once they get to the 6 to 12 years old, sometimes their activity levels really slow down. And my opinion is that there's a lot more video games in this age group. And I will say I'm guilty. My son has an Xbox, and I hate this stupid thing. I swear I fight with that more than I fight with anything. But this is the age group where obesity is common. For health assessment and promotion, our biggest thing is, yes, we're still going to ask questions of the caregivers, but we're really going to encourage that kiddo to um, interact with us and tell us what they're feeling. Are you having any pain today? Can you tell me? And is it a sad face? Is it a mad face? So let them tell you what they're feeling or what they've experienced rather than just going by what off the parent says. Because sometimes they'll tell you, as the nurse, they'll tell you more than what they'll tell their parents. All right. Health promotion in the adolescent, the 12 to 18 years old. Adolescence is a period in which they're a child, but they're becoming physically and psychologically mature and becoming an adult. This is the time frame where they get themselves ready to enter adulthood. Puberty, we know that is the beginning of stage which the sexual organs are maturing, growing, where they grow breasts and pubic hair. Menarche is the onset of their first period, and ejaculation is the expulsion of semen. So, adolescent growth spurt. Girls are going to have their growth spurt when they're between 10 and 14. Boys are going to have their growth spurt between 12 and 16. The boys generally have their growth spurt, I don't know, at least a year after um, the girls, and it can be a lot. They can be pretty stressed out about it. Hold on a second. Go let that down. He just looked at me and turned around and walked back to bed. That works. Anyway, so the boys might actually be really stressed out about how come my friend um, Cassie is 6 inches taller than me. I'm a boy and I'm supposed to be bigger, but it's just because their physical changes and their growth spurt actually occurs sooner in girls than it does in boys. Boys can actually double their weight and grow about an inch and a half. Um, Generally, the girl's going to grow about 9 inches and gain like 50 pounds. Really need to educate these kiddos about these growth spurts um, and what goes into all that, the hereditary factors, nutrition. Yes, they're gaining weight, but is it good weight, or are they eating or not eating because of them being a teenager and being bullied? Really need to educate them on their medical care, mediocre, I don't know what I missed a C in there, but their medical care, because for mental health and reproductive, at the age of, I think it is 12, they can actually be independent in that. We cannot speak to their parents about those two things. They may be taking in more calories. We'll get into that in our diet section. So we really need to try and encourage this healthy balance of snacks, healthy foods, and exercise, because kiddos nowadays have a terrible, terrible schedule and they eat what's handy. All right. So, psychological development. These kids are going to be in identity versus role confusion. They are going to try and figure out their identity, but they still may become confused because they're going to take everybody's recommendations and what they think everybody wants them to be, and so they may get a little confused. A big thing in this age group is that they want to be accepted by their peers. Peers are more important than anybody during this time. Cognitive development, they're starting to actually think above and beyond. They are absorbing all of this knowledge and they're figuring out how to use it. Moral development, they can live by the golden rule, treat others how you want to be treated. And they may actually start developing their own value system. They might get rid of, discard or get rid of some of the values that their parents kind of instilled in them growing up and have their own values, which is okay. It takes a little while to get used to that whole idea, but they may begin figuring things out for themselves. Spiritual development, they are going to start their own thoughts and their own ideas of religion. Health risks. This is a major issue for teens. Their injuries and their illnesses are all related to their behaviors. They have a lot of risky behaviors. So they might be smoking, they might be using drugs, they might be using alcohol. A lot of teens are actually becoming sexually active and may become pregnant, or they may get a STI. Honestly, I have one of my daughters is 16, and I am almost appalled at the number of students in her grade that are sexually active without protection, and the amount of just the STDs going around just that class. It's really kind of scary. Their diets are generally going to be unhealthy because they're busy. They're keeping up with their friends. They're involved in this sport and that band and drama, and so they're just kind of eating what's out there. They may become physically inactive. Like I said before, video games are a huge thing. Um, Phones or tablets are really contributing to the obesity and inactivity. Motor vehicle accidents are a huge risk for this age group. They're just learning how to drive, but maybe they don't know how to react in the snow, or maybe their friend texted them and they picked their phone up. Um, so they're just really kind of learning how to. They've got all this responsibility with their driver's license, but that's a huge risk for them. Suicide is a high health risk for them. There's a lot of bullying in schools, and that is one of the number one reasons for um, a teenager to commit suicide. There is eating disorders. Also, maybe they were bullied when they were younger because they were chubby, so they'll develop anorexia or bulimia, and then like cutting, or they're not doing it to commit suicide, but they're just cutting to release the anger to get the release. So those are all the health risks related to adolescence, and basically it's because they are feeling, oh gosh, what's the word? Unstoppable. That can't happen to me. You hear about all these car accidents. Well, that can't happen to me until it does. So, um, health assessment and promotion for teenagers. They can really start being more self-directed, but they do need some direction on which way to go and what they need to do. Screenings include tobacco, alcohol, drug use, sexual practices. So they're going to start getting the Pap smear, those types of things. Mental health status, and to really make sure that they're current on their immunizations before they head off to college. This is kind of the break where they don't get a whole lot until they're, 18-ish, close to 18, where they're getting ready to go off to college. Maybe they'll get the meningitis vaccine. All right, young adults. Physical development. This is where their highest physical functioning at about 25. There isn't a whole lot of physical changes that happen, but this will be ages 20 to 40. So their psychosocial development, or their Erikson's stage, is going to be intimacy versus isolation. So once they've gotten through the terrible teenage years, they're going to start, they've kind of got an idea of who they are because they went through the identity versus role confusion. So then once they have themselves, they're going to start looking for others to join in into their life, whatever type of relationship they want. They'll choose their life partner. They'll move in or live with their partner. They'll consider starting a family. They'll consider marriage. Maybe they're going to start buy a home, and have children. They're going to make choices regarding education and career. So they're really trying to determine, to get this intimate sense of self versus feeling isolated. Hope that makes sense. Cognitive development. They're pretty well developed. They can use formal operations, think outside the box, use logic. Moral development. They're going to develop their own morals. They'll take in everything that they were taught as kids. They'll take in everything that they've learned throughout the years, and just develop their own morals. Spiritual development. They're what they learned growing up about religion. They'll either accept it or they'll tailor it to what they want to do. Maybe they grew up in a very, very, very strict Catholic, and once they get out, they want to be, an atheist. Or when my brother was like 38, I think, We were actually brought up Lutheran, and he actually wanted a stricter religion. So he began going to a Catholic church and was rebaptized Catholic when he was 38. So they kind of get their own what they want for religion. Health risks. Uh, health risks. There's suicide and high blood pressure, um, injury, violence. Maybe they're 22 years old and they're out at the bar and they start a fight and they get hurt. A lot of health risks are related to substance abuse, um, STDs, eating disorders is high in this risk or in this age group, um, and cancers do happen in this one as well. So the risks are related to some of the high risk behaviors that this group engages in. If you look at it, they're just starting to be able to legally drink. They're just starting to be out and about on their own. So they are able to make all these decisions of whether they're going to drink, whether they're going to smoke weed, whether they're going to hook up with somebody at the bar that night. So all these high risk behaviors actually will cause different health risks. So health assessment and promotion, they're really, they may be interested in meeting their health needs, but a lot of times this age group is going to need education as to what tests they need, what screenings they need, things to do for safety. If you are taking care of a patient and they come in for an STD screening, make sure you are preaching to them the importance of, protected sex. So safety, or the importance of not drinking or driving, and provide them with maybe the cab number if they're going out to drink or whatever. So they just may need a little more extra boost, a little education. Middle-aged adults, physical changes are starting in the 40 to 65 age group. Menopause is going to start happening for the female. There's going to be less skin moisture, so they're going to start having wrinkles. Their skin turgor is going to be tenting, and there's less subcutaneous fat as well. This age group, their metabolism is actually going to decrease, so this is when they start putting on weight. Sometimes people will say, well, I ate just like I did when I was 30, but now I'm gaining weight. Because the metabolism decreases. The psychological development, the Erikson stage, is generativity versus stagnation. So generativity basically means they're concerned for the next generation. What are they doing to provide or teach or get the next generation ready for what they did? Stagnation is just basically means they're stagnant. They're bored, impoverished. They have problems accepting their aging bodies, and they might become withdrawn. This is the part where they actually have that midlife crisis where they might regress back to their teenage development, where they're unstoppable and they're going to go out and get a fast car and they're going to start drinking and they're going to find a girlfriend, and so this is the stage where they have that midlife crisis when they feel like they're stagnant. Cognitive development, there's very little change. Moral development, actually their morals really escalate in this age group. Example, my brother-in-law is 46, and growing up until he was probably 42, so it's just been a recent change. Yeah, it was probably 42. But growing up, he was a hall raiser. He was just, I don't even know how to explain him. He really didn't have any morals that we would consider now. I mean, he was he generally wasn't a very nice guy, but something switched in him a few years back, and he having his son really changed him, but now he has more morals than I've seen in a lot of people. His son is raised with respect. Everybody is ma'am, sir. When he sees people, he holds the door open for them. He was never a religious person. Now he's going to church every Sunday. So it does happen in this middle-aged adult where they actually develop more morals or define their morals. Spiritual development. A lot of people in this age group really feel more comfortable or find comfort with religion. If they are having problems with life events or stressors such as, maybe one of their loved ones passed away, they're going to rely on their belief in God or whatever they believe their higher power to help them get through that issue. I'm sorry, my belly's gurgling. I don't know if you guys can hear it. Health risks. A lot of the health risks in this middle-aged adult is going to go back to what they did in the early adults. Their lifestyle patterns from when they were running around raising hell, drinking, smoking, are going to show up in this time frame. So if they're smoking and they're drinking, they might have respiratory problems, which can escalate into lung cancer, and maybe their drinking has given them liver disease. Or maybe in their 20s and 30s they were overeating, so now they are obese, they have diabetes, they ate a lot of cheeseburgers, so they have atherosclerosis and hypertension and coronary artery disease. So everything they did in their early adulthood can actually come, this is when it's going to show up. So their leading cause of death during this age is the motor vehicle and work accidents, chronic disease caused by poor lifestyle choices in the earlier years, and the cardiovascular disease, which a lot of times is related to what they did in their early years. Middle-aged adults were really encouraging, especially the women, to have their mammograms because in this age group there is a very high risk of them starting to develop cancers. Lung and breast cancer are the two main ones of this group. So we really need to encourage them to start having mammograms during their middle age time. Men also have a high risk of developing cancers. Their cancers are generally the lung, the prostate, and the colon cancers. So at this age group, we really need to encourage them to get their PSA screening done and their colonoscopies. So if you remember, during this age, depending on what, if male or female, what they and their common cancers are, but they need to have their screenings done. Middle-aged adults, health assessment and promotion. This age group is generally interested in taking care of their healthcare needs because it's more in their face of, I have diabetes and now I've got neuropathy in my feet. It's in their face. It's something they have to deal with. So a test that they should be screened, health test and screening. I can't talk anymore. It's like 1 o'clock in the morning. But we recommend yearly physical exams, immunizations based on their ages, like the flu shot every year. Once they get into the middle age, we're going to recommend a shingles vaccine and a pneumonia vaccine, those types of things. So the immunizations based on their age group. Dental assessments. We're going to encourage them to have the breast and testicular exams, whether it's a mammogram or a PSA or something like that. We're going to have them screened. We want to encourage them to be screened for cancer, like I was talking about earlier, and then any cardiovascular assessments we want done. Older adults, anybody over the age of 65. There are a lot of physical changes. Their skin's going to be drier. They're going to be pale. Their skin is going to tear very easy. If any of you have ever worked in a nursing home, you could bump somebody of this age group and their skin rips and they're bleeding and they're going to have brown age spots, and this group doesn't really sweat. Neuromuscular, you'll hear them complain that they're getting shorter. Their joints are stiffer, their reaction time is slower, so that's why we're really watching their driving. Maybe they're not fit to drive anymore because if somebody pulls out in front of them, sometimes they can't stop in time. They're having trouble learning new things because this is the way they've always done it, so why would they do it differently? Their vision is going to be decreased, their smelling, their hearing, taste, all of that decreases. They're going to have more problems breathing. Those lungs are getting old and they're not as elastic and they don't have as much surfactant, and they're just going to have problems breathing. Cardiovascular, they're going to have higher blood pressures. They may be orthostatic related to their illnesses or even their medications. Anytime there's like an antipsychotic medication or a blood pressure medication, they may be orthostatic. GI, they're going to have more constipation. They might have more heartburn. And if you've ever met anybody, some little old person, they are 9 times out of 10 focused on their bowels. I used to take care of a lady who would write down every time she pooped, whether it was a tiny little rabbit poop, this is how she would word it, or it would be a big, huge, humongous poop. I mean, yeah, she kept her diary, so we could go back for 2 years and see how many times she pooped. Urinary, a lot of the kidneys are going to start decreasing in their function. Older people are going to have a lot more where they're not able to sleep through the night without getting up to pee. Their immune system is going to be decreased. They're going to catch a lot more illnesses a lot easier. Endocrine, insulin response might not be as good. Thyroid function might decline. So there are a whole lot of physical aging signs. Ego, integrity versus despair. If you guys have made it through first semester, you have written this on your data sheet. Ego, integrity, this is just basically when the person feels satisfied with what their accomplishments are. They're satisfied with their life. They can say, I lived a good life. So when they talk about death, they really feel like, hey, yeah, I can accept it. I've had a good life and I'm ready to go. Most of my friends are gone, so I'm ready. I'm done. I'm proud of everything I've accomplished. I got a nice family. I provided for my family, whatever it is. So I'm ready to go. I mean, it's not a suicidal thought by any means, but I'm done. I did a great job. Despair. People are going to feel like they've made poor life choices. Maybe I don't know. They remained a bachelor, but wish they would have had children. But that part of their life is able and they can't go back. So this is where they feel despair, where they're not happy with how their life turned out. Cognitive issues. Sometimes they might actually have a decrease in the ability to interpret their environment, like the sense, the smell, the feeling. Their cognitive agility might decline, but this is not normal stage of aging. If their cognitive function is declining, it is related to something else like Alzheimer's. Kind of goes over the memory. I don't want to go through that. You guys know what short-term memory is, recent memory, and long-term memory is. Moral reasoning. Their moral development actually happened at a different time than the other age groups. So their morals are going to be very, very different than what today's average morals are. Their religion is going to be different. They were brought up differently with their church. For example, morals in church. This picture down here is an older picture of a family dressed up for Easter Sunday, the Easter bonnets. On Easter Sunday, every girl had a new dress, and they also wore a hat with their dress, their Easter bonnet. That doesn't happen quite as much anymore. They may get a new dress or whatever, but um, their morals and their religion was totally different back when they were growing up than it is now. Health problems. Most of the health problems related to the older adult are chronic diseases. There might be injuries related to falls. Um, their drug abuse or misuse, and that doesn't have to be on purpose. Maybe, the example I gave in, I don't know, I think it was week 1. Maybe they see on their pill bottle it says once, but they're Spanish speaking and they read it as once, which is 11. Or maybe they're just not understanding when to take their PRN pain meds and they're taking too many or too little. A lot of times they may turn to alcohol. Their spouses passed away, um, so they become an alcoholic after that because they have really maybe they didn't never had children, they don't have any family. Dementia is a huge factor in the older adult, and mistreatment, elder abuse. Health assessment and promotion. We're going to really encourage them to have physical assessments yearly. So when we are doing our interview questions, we really want to touch on their depression, their suicidal thoughts, or their abnormal bereavement. Suicide is actually very high in the elderly population because if you look at it, they've generally got more than one chronic illness. Maybe it's terminal. Maybe they were diagnosed with cancer. Um, Maybe their spouse of 60 years has passed away, and like I said, they don't have children, so they don't have any family. So they are at a high risk for suicide. Their cognitive function may be declining related to, um, Alzheimer's, or if they have Parkinson's, their dementia will set in from that. We want to talk to them about their medications, and a lot of time this group may not know their medications by name, but if you have them bring it with, you can pull it out and say, okay, what medicine is this, or when do you take this medicine? And based on the color and the shape, they'll tell you when they take it, and sometimes they can tell you what it's for based on that. We really need to make sure that we're asking them about physical abuse or neglect. Um, it is common. It's sad, but these people are getting, Social Security checks, and maybe their family members, doesn't have a whole lot of money, so they are um, relying on their Social Security check. I took care of a lady who um, lived through World War II and was in a concentration camp. And with her dementia, she was actually stuck there. But when she was at home after she was no longer mobile, her family did not want to, I don't want to say they didn't want to care for her, but I don't even know if it was her family or just a group home or what. So she would get up in her chair at 4:30 in the morning before whoever it was left for work or whatever, and they would really limit her food and her fluid intake because if you drink or you eat, you have to go to the bathroom, and if you have to go to the bathroom, then that makes the person taking care of her has to actually do something. So it was a really huge case of neglect. The county got word that she was staying there and that she was not being cared for appropriately, and she was removed from the home immediately and put in a nursing home. And I tell you what, I have never seen a little old lady eat so much. For the longest time, every time she got near food, she would just shovel it in. She was scared that we're going to stop giving it to her, and she wasn't going to have any. So really watch your elderly people. I also had a case where the lady was in her 70s, and she lived at home with her husband and her son. and she came into the ER for, I don't know, something, maybe cardiac, chest pain, I don't remember. But they had asked her in front of her family, do you feel safe at home? Is there any issues at home that we should be aware of? Nope, I'm good. And she put on her light on to go to the bathroom, and the next nurse was just trying to help get some of the questions answered and didn't figure that she had been asked about her home life yet. So as she's taking her to the bathroom after she closed the door when she had her by herself, she says, "So are you feeling safe at home? Is everything okay at home?" And the lady actually started bawling and said, no, it's not. So always make sure we're doing our physical abuse or our neglect screenings when we get these elderly folks, because even if you ask them in front of their family, they're going to tell you it's fine, even if it's not, because they don't want their abuser to know. But if you can ask them when they're away from their family members, you're going to get a more truthful answer, I guess. We need to ask them if they have any skin lesions. Their skin is so fragile that, and their circulation is so poor. So between their circulation and their fragile skin, they may have, they're at a higher risk for pressure injuries. I can't talk today. Sorry, I'm getting tired. So, things that affect safety. How much do we have left? Oh, not a whole lot. I don't know why it jumped to there. Alright. So, things that affect safety. I don't want you guys to spend a whole lot of time memorizing all this. But age and development affects safety. Basically, it's experience. People are learning how to protect themselves from injury. They're learning to look both ways before crossing the street. They're learning not to touch a hot stove. Lifestyle is a factor that might affect safety, depending on what their work environment is, or maybe they're choosing to live in a high crime rate neighborhood, in the ghetto. Maybe they're doing risk-taking behaviors. They're going out Friday night and drinking until Sunday morning. Yeah, those types of things. Whatever their lifestyle might affect their safety status. Mobility and health status. If a person is less mobile, they're at a higher risk for health-related issues, whether it's pressure injuries or obesity. There's just a whole lot of things that go with decreased mobility. Pneumonia, sensory perceptual alterations. People that have impaired touch, hearing, taste, smell, and vision obviously are at a higher risk of injury. Decreased cognitive abilities can put somebody at a higher risk for injury, or keeps them from responding appropriately if they're less cognitively aware. It doesn't have to just be Alzheimer confused patients. It can be people who haven't slept, because when you guys are sleep deprived because you've got 16 million things going on, you don't think clearly, or altered judgment, whether they're drinking or on drugs. So all of these things factor in. Emotional status, depending on their emotional state. If they're really stressed out, they may not see the environmental hazards that are right in front of them. They may just totally breeze by and never see it. If these people are unable to communicate, whether it's a language barrier, or they're got a poor health literacy level, or they can't read, or they just can't talk, they're at a bigger risk for safety. All these are pretty much common sense things. Safety awareness. Patients that don't have this safety awareness, like I talked about the little kids, maybe they don't realize that the stove is hot and that if you touch the hot stove, they're going to get burned. Or maybe they don't realize that if they fall off the side of the deck, they're going to break their leg. Healthcare setting, environmental factors. In the healthcare setting, they're really trying to get away from the punitive approach to medical errors. So if a person reports, hey, I gave so-and-so a blood pressure med and I meant to give it to this other patient, they're really trying to get away from the nurse getting written up or getting any sort of discipline, because if I'm going to get disciplined, I'm not going to report it. Yeah, it's not ethical, but that's the way it's happening. Is if you're going to get disciplined for reporting your own medical error, a lot of times people won't report it. So there's a lot of issues that affect the safety of the patients when people aren't reporting any medical orders. So ethically, if you ever do complete a medical error or a med error, which I'm not going to lie, there will be a time in your career that there will be a medication error. Just make sure your patient is safe. I will tell you mine happened in 2008. Yeah, 2008. I received a med list off of a patient's chart. I went and sat with the patient and said, okay, can you what meds do you take? He goes, I don't remember the name of them. And so I said, oh, well, do you take this one? Yep. Do you know if it's this amount? And went through his whole list. He said, yes, I take that. And yeah, I think that's how much I take. I actually took the med rec to the doctor. The doctor ordered them. I pulled them out of the Pyxis. I gave them. The guy was actually suicidal. And he really didn't know much about his meds. So, because I was working in inpatient psych. And I brought him a cup full of meds. I mean, it had some sedating medications in there. I think there was Risperidol and Haldol. I don't remember exactly what was in there, but brought him his meds and said, okay, I did all the checks. And that was before we scanned every med, but it wouldn't have mattered because they were ordered. Down the hatch they went, and as he's taking a drink, he says, so, he took a drink and said, why do I have so many meds? I don't take this many at home. So yeah, as hard as it was, I did go back and report to the doctor, and sure enough, he did have some issues with, being sedated from his medications. But had I not reported that to the doctor right away, there would have been some serious things that could have happened. So I think that, oh, nope, I still got more. Workplace, environmental workplace. If you think about it, factory workers are at risk for, machinery, injuries related to the machinery, the belts, the pulleys, chemicals. Nursing, we get exposed to infectious diseases. We're lifting patients, we're bending, we're walking. We're at risk for needle stick injuries. So those are all kind of safety issues. Home. One big takeaway from the home is if we are sending our patients home, so maybe they had a hip surgery and they're in the nursing home, and they are ready to be discharged, we want to make sure that they are removing any throw rugs, because that will prevent any further falls. We need to make sure that these places are safe for our patients. Yeah, and community. You guys can read these. And that is it. We made it through. So, if you guys have any questions, oh my goodness, it was an hour and a half long. I did kind of babble tonight. But if you guys have any questions, let me know. I will get this posted yet tonight. And then I will probably get the other one recorded in the morning. But I am early. I want to have these done by the Monday of the week that they're supposed to open, but I am ahead of the game. So I'm going to try and stay ahead of the game. Hopefully. All right. Have a good night, guys.